the plates and the books use those. All right, so good afternoon, everyone, and I welcome you all to this YouTube session. So I'm myself, Dr. Rajesh Gubba. I'm the General Medicine Educator for Arise Medical Academy. So here I'm there in front of you to discuss the clinical based questions in the general medicine. So for the upcoming FMGE exam, in order to see that you should not face any difficulty, we at Arise Medical Academy have planned this particular special sessions, which are the clinical based discussion. Yeah. So yes, Bhargavi, I think I am audible now. Okay. So please tell me, what is this alendronate? Yes, I hope I am audible to everyone now. Okay, right. So the question is, when should the bone densitometry testing be repeated to assess the response to the therapy? 1 year, 3 years, 5 years, 10 years, and it does not need to be repeated. MRI should be performed instead. So in these questions, what all I want is, I want you to tell me what is T-score, right? And you should know what is Z-score, right? And you should know what is the normal T-score, right? And you should know what is this alendronate. So please tell me all these now. And she is 38-year-old woman. And another question what I want to ask you is, why this patient has vitamin D deficiency? Why this patient has vitamin D deficiency? So please tell me the answers to all these questions. Right, so who will be the first person to answer this? Right. Let me explain you that this particular patient is suffering with what is called osteoporosis. Sir, why are you telling that? Why are you telling that this particular patient is suffering with the osteoporosis? The reason is that the T-score minus 2.8, it is suggestive of osteoporosis. Right? T-score minus 2.6 is suggestive of osteoporosis. Sir, then what is the normal value of the T-score? The normal value of the T-score, if you see, minus 1 to 0, right? So more than or above minus 1 will be normal bone density range. And if the T-score, if it is in between minus 1 to minus 2.5, this is your osteopenia, right? Where there is decrease in the bone density. And minus 2.5 below, it is your osteoporosis. Now, what is the T-score of our patient? Our patient T-score is minus 2.5. So minus 2.5, it is clearly suggestive of osteoporosis. Right? It is clearly suggestive of osteoporosis. Right? Now, at the same time, you should also know what is the Z-score. At the same time, you should know what is this Z-score. Right. Now, let me tell you what is T-score and what is Z-score. See, how do we calculate this particular T-score is? T-score is nothing but it is a comparison of the person's bone density with that of a 30-year-old healthy individual of same gender. That is your T-score. Then what is Z-score? The difference is the age group at which we are comparing. In T-score, we are comparing the bone density of the individual with the 30-year-old individual of same gender. But whereas in case of Z-score, in Z-score what we do is, we compare the person's bone density with that of the same age and as well as the same gender. That is what is the difference between the T-score and as well as the Z-score, right? But in between these two, which is most useful in measuring the bone density, it is your T-score which is more useful, right? It is your T-score which is more useful, okay? And what is given in your question to you? It is the T-score which is given in the question to you, right? T-score of minus 2.8. That means the patient is suffering with osteoporosis. Now, the next point is, what is alendronate? Can anyone tell me what is alendronate? Yes, what is alendronate? Any one of you, please? All right. So alendronate, it is a bisphosphonate. Right? And this is given for the treatment of osteoporosis. Right? This is given for the treatment of osteoporosis. Now, very good, Bhargavi. Now, what are the other examples of your bisphosphonates? We have zoledronic acid. Right? We have zoledronic acid. Then we have ibandronate. And then we have alendronate. Right? Then we have what is called alendronate. Okay, so these are your bisphosphonates. Now our patient is on the alendronate. Now, what is the next? Another question. What did I ask you in this? Why this particular patient has vitamin D deficiency? Right? Why this patient has vitamin D deficiency? Why? Because in patients with cystic fibrosis, right? In patients with the cystic fibrosis, they have malabsorption. Right? They have malabsorption. Okay, so because of the malabsorption of, that means there is reduced vitamin D absorption across the intestine, and because of this malabsorption they will have vitamin D deficiency, right? Because of this malabsorption they will have vitamin D deficiency, right? So that's a very, very important point. Now we are very much clear about the question. So vitamin D deficiency is because the patient is suffering with the cystic fibrosis, and because of vitamin D deficiency the individual is having osteoporosis. Now for the osteoporosis the patient is taking alendronate, cholecalciferol, that is vitamin D, calcium carbonate, that is calcium supplementation. Now what actually is our question now? When should the patient densitometry testing should be repeated to assess the response to therapy? Right, should be repeated to assess the response to therapy. Always remember, whenever you are giving these particular drugs, these drugs, they don't have very quick onset of action, right? These drugs, they don't have very quick onset of action. They don't immediately treat your osteoporosis. These medications, they take nearly several years to produce the significant changes, right? To produce the significant changes within the bone mineral density. So you need to repeat that particular bone densitometry after 2 years, right? You need to repeat that particular bone densitometry after 2 years. Okay, so the answer in this particular question now is your 3 years. Why? Because you don't have 2 years as an option. The earliest will be more than 2 years. So what will be the best answer here? That will be 3 years. Okay, so this is a, and what is the response you have to see now? The T-score which has become minus 2.8, it has to become minus 2.5, minus 2, minus 1, and then 0. That is what is called as the positive response whenever you are giving this particular bisphosphonates, calcium supplementation, and as well as vitamin D supplementation. So the answer to this question is 3 years. Okay, right. Now we will move on to the next question. But before that, what are the various treatment options for the osteoporosis? What are the various treatment options for osteoporosis? Right, this is another important point that you should know. That is, number one, bisphosphonates can be given. Our patient is taking bisphosphonates, that is alendronate. Then, okay, I think you are unable to see over the slide there, right? I'll just write it. Bisphosphonates already you are aware of. The next group of drugs is denosumab. Next we have selective estrogen receptor modulators. Then we have strontium ranelate. Right, next we have activated vitamin D. Right, activated vitamin D and recombinant parathormone. Right, recombinant parathormone. Okay, so these are all the various formulations what you have. Right, these are all the various supplement, I mean these are all the various options for the treatment of the osteoporosis. And what is our patient taking? Our patient is taking bisphosphonates, our patient is taking cholecalciferol, that is vitamin D, and our patient is taking calcium supplementation, right? And when should the repeat bone mineral density should be done? After 2 years. And in our option given to us, the best answer there is 3 years. Okay, right. Now, so what was this question about? This question is about how do you diagnose osteoporosis? How do you treat osteoporosis? How do you monitor osteoporosis? So this question is related to your osteoporosis. All right. Now we will move on to the next question. Yes, this is another very interesting question, and let me see how many of you can crack this question. Right? And let me tell you, in your upcoming FMGE exam, you will be definitely having lengthy clinical based questions. So you should practice as many as possible lengthy clinical based questions in order to see that you should not have any difficulty in your upcoming FMGE exam. So please don't get scared by seeing these type of questions, and you should face these questions. Okay, so we have a 19-year-old woman is evaluated by her primary care physician for recurrent long bone fractures. So what is the concern about of the 19-year-old woman? Long bone fractures. She has fractured femur twice. She has fractured her humerus thrice. And she has not had an abnormal number of falls and reports also having easy bruising, right? So it was not a very great fall which would lead to fracture in a normal individual, but this individual had recurrent fractures in spite of a minimal fall. Aside from these repeated orthopedic injuries, she is otherwise normal, healthy, right? She is otherwise healthy. Physical examination shows mildly disfigured bones, small amber yellowish teeth, bluish colored sclera. Based on these findings, what you have come to the conclusion is, you have come to a conclusion that, okay, this patient is suffering with the osteogenesis imperfecta. Now, what is the very important point of osteogenesis imperfecta? The very important point of osteogenesis imperfecta is recurrent fractures, right? Recurrent fractures, that is one thing. And the other important thing is the bluish colored sclera. The other important thing is the bluish colored sclera. Now, which one of the following statements is true regarding this condition? The options are: mutation in type 1 procollagen likely is present in this patient. Bone biopsy is needed for definitive diagnosis. Bisphosphonates have shown long-term success in prevention long bone fractures in this condition. Fractures in female tend to increase after puberty. Increased bone mineral density may be demonstrated on X-ray absorptiometry. Yeah. So now what is the answer which is true regarding this osteogenesis imperfecta? Anyone? Right? Yes, someone should make an attempt. Very good. So Shahid Afridi is answered very nicely. So a mutation in type 1 procollagen likely to be present in this patient. So now what is this osteogenesis imperfecta? Osteogenesis imperfecta, it is a disorder of the connective tissue. Right? It is a disorder of the connective tissue. So in this patient, what exactly happens? In this patient, there will be mutation in type 1 procollagen, right? Mutation in type 1 procollagen. Now, how many types of osteogenesis imperfecta you have? Osteogenesis imperfecta, you have two types, right? Type 1 and as well as type 2. Right, type 1 and as well as type 2. So these are the two forms of the osteogenesis imperfecta, or two types of the osteogenesis imperfecta. Now let me discuss both the types, right? I will tell you important points about both the types, but you should know that osteogenesis imperfecta is due to mutation in type 1 procollagen, right? It is due to mutation in type 1 procollagen. Now, so osteogenesis imperfecta, it is an heritable disorder of the connective tissue, and there is severe decrease in bone mass that makes bone brittle and prone to fracture. And why does this particular osteogenesis imperfecta occurs? That is due to deficiency or abnormality of type 1 procollagen, right? That is due to deficiency or abnormality of your type 1 procollagen. So that is what our first option is. That is what our friend Shahid Afridi has answered. So the answer is deficiency or abnormality in type 1 procollagen. And we have discussed that it is an heritable disorder. What type of hereditary disorder is your osteogenesis imperfecta is? It is your autosomal dominant type of inheritance. And based on the clinical phenotype of the disease, we have several subtypes. But here at this moment, I will discuss the two important subtypes, that is osteogenesis imperfecta type 1 and then osteogenesis imperfecta type 2. Now let me take up the presentation of type 1. See, in case of type 1, they have mildest bone disease. right? They have mildest bone disease, and there is minimal or no apparent skeletal deformities, right? With minimal or no apparent skeletal deformities. Okay, and this particular disease of type 1 osteogenesis imperfecta, it is not present until the adulthood, right? Until adulthood, you don't have this manifestation of type 1 osteogenesis imperfecta. Whereas you take type 2. Type 2, see, what was your type 1? Your type 1 is mild form, right? It is a mild form of the osteogenesis imperfecta. Whereas type 2 osteogenesis imperfecta, they have very brittle bones, right? They have very brittle bones. And these patients, let me tell you, they are lethal in utero or shortly after the birth, either immediately after the birth or within the uterus. They have very severe manifestations, right? They have very severe manifestations because they have very brittle bones. Remember, they are prone for frequent fractures. They have bony deformity in the form of kyphoscoliosis, right? They have bony deformity in the form of kyphoscoliosis. And another important clinical manifestation of type 1 include blue sclera. And why does this particular blue sclera occurs? That is due to thinness of the collagen fibers of the sclera. So the collagen fibers of the sclera, they are very thin. Okay. Now, because the collagen fibers of the sclera is very thin, through this particular sclera, the choroidal layers can be seen. Right? The choroid layers can be seen. Now, these choroid layers, they are bluish in color. And that is the reason why you will have this blue sclera. Right? That is the reason why you have this particular blue sclera. Right? So that is about the type 1 and as well as type 2 osteogenesis imperfecta. Right? And even if you take the color of the teeth, they are yellow or amber colored teeth. Okay? Right. And hearing loss is another important manifestation. Right, that is seen in almost more than 50% of patients, hearing loss, right? And as the puberty, after the puberty, the fractures, they will decrease, right? Fractures, they will decrease. But again, during pregnancy and as well as after menopause, at this moment of time, the fractures, they do increase. But after puberty, the fractures will decrease. Right? After puberty, the fractures will decrease. Okay? Right. Now, how do you diagnose? Number one, autosomal dominant nature of inheritance, where the individual will have the family history of the disease. And these individuals on DEXA scan, right, on bone densitometry, you will notice decreased bone mineral density. Right, you will notice decreased bone mineral density. And in these patients with osteogenesis imperfecta, remember, bone biopsy is not required. Right, bone biopsy is not required. Then what is the treatment for osteogenesis imperfecta? There is no specific treatment. You need to treat the underlying complications. Right, you need to treat the underlying complications. Okay. Right. And yeah, so although bisphosphonates are well tolerated and often used for moderate to severe disease, where they may decrease the bone pain and fracture risk, their long-term and safety in osteogenesis imperfecta is unknown. So what is the safety and what is the use in long term? Right, it is completely a questionable importance. Right, completely a questionable importance. Now I will go back to the question again. So you see this question, 19-year-old women, recurrent long bone fractures, right? Femur fractured twice, humerus fractured thrice, and abnormal. And the other important thing is physical examination shows mildly disfigured bones, yellow colored teeth, blue colored sclera. So the presence of the blue colored sclera, yellow teeth, recurrent fractures, that tells you it is a case of osteogenesis imperfecta, right? And osteogenesis imperfecta, how do you diagnose? By your family history, autosomal dominant type of inheritance, and by your genetic analysis, that is type 1 procollagen. Bone biopsy will not give you definitive diagnosis. And there is no specific treatment for your osteogenesis imperfecta, right? Bisphosphonates have shown long-term success? No. Right? Long term, the importance of this bisphosphonates, it is completely questionable. Right? It is completely questionable. And fractures in females tend to increase with puberty? No. They will decrease after puberty. And increased bone mineral density may be demonstrated on no. On bone densitometry, you will notice there will be decreased bone mineral density. Right? There will be decreased bone mineral density. Okay, so that completes, right, that completes the discussion of the osteogenesis imperfecta. Now, what is the cause of death in these individuals, right? So number one, because they have recurrent long bone fractures. Yes, Asadullah Khan, please tell me what is the complication which is anticipated on recurrent long bone fractures? Yes. Yes, Asadullah Khan, due to recurrent long bone fractures, what is the complication that can be anticipated? Estrogen will, yes, very good, Chandrasekharan. So they are prone for the development of the fat embolism, and that would lead to the death of the individual. Right? That would lead to the death of the individual. Right? Asadullah Khan, is that clear? Now, and the next point is, you are asking, sir, how estrogen is cardioprotective? Let me tell you, estrogen in physiological levels, right, in physiological levels, they will increase the HDL and they decrease the LDL, right? They will decrease the LDL. That is what is your estrogen, and that is the reason why it is your cardioprotective. That is the reason why it is your cardioprotective. So this is a case of osteogenesis imperfecta. So what you should know now, osteogenesis imperfecta type 1 is a mild form. Osteogenesis imperfecta type 2, it is a more severe form, right? It is a more severe form. In utero or during the fetal life itself, they will have recurrent bone fractures. Which one? Osteogenesis imperfecta type 2. Whereas type 1, until adult life, the manifestation will not be there in type 1, right? So this finishes the topic of osteogenesis imperfecta, where you have mutation type 1 procollagen. Now, we will move on to the next question. Right, so question is looking very lengthy, but answer is very simple. Let me tell you, right? So concentrate on the question. Please don't get scared by seeing these type of questions, right? And understand the concept, hit the question, crack the exam. Okay, so 53-year-old women presented to your clinic complaining of transient episode of diaphoresis, asthenia, near syncopal attack, clouding of thought, and she has had these symptoms for several months. These episodes most commonly occur several hours after she eats, and she has no other significant medical history and takes no medication. A prolonged fast is begun, during which the patient has become symptomatic. Her glucose concentration at the time is 43. The insulin levels are elevated and no insulin antibodies are present. The C-peptide level is also high, and the test for the sulfonylurea and meglitinides, they are negative. What is the most effective therapy for this patient? Right? What is the most effective therapy for this patient? Observe the patient and schedule a follow-up fast 2 to 3 months from now. Adjust the patient diet to include smaller, more frequent meals. Obtain the transabdominal ultrasound and refer the patient to the surgery for resection. begin the diazoxide 400 milligrams thrice daily, verapamil 180 milligrams thrice daily, and have the patient appear for follow-up within, have patient to appear for follow-up visit in 3 months, begin phenytoin, right? Begin phenytoin and octreotide and have the patient appear for follow-up visit in 3 months. So we have a doctor. Yes, we have a user by name, we have a learner by name doctor. Yes, doctor, you have opted C, then you have deleted, and then you have answered D. Right. So do you think that whatever you have decided, is it correct? Okay. So please tell me what is the diagnosis? And Shahid Afridi also said D. Doctor also said D. Now, please anyone tell me the diagnosis. Tell me the diagnosis. Any one of you? Very good. So we have correct answer from Chandrasekharan. So Chandrasekharan said, obtain a transabdominal ultrasound and refer the patient to surgery for resection. Very good, doctor. So now doctor has come up with the diagnosis also, that is insulinoma. Right? Insulinoma. Okay, that is the diagnosis. Now in insulinoma, now let me discuss few points about the insulinoma. Okay, now if you take this insulinoma, it is characterized by a triad. What is the triad? Yes, insulinoma, it is characterized by a triad. What is the triad of insulinoma? So this particular triad of insulinoma, we call it as, right, we call it as Whipple's triad. Right, we call it as Whipple's triad. What is Whipple's triad? These individuals, they will have the clinical features of hypoglycemia, right? These individuals, they'll have the clinical features of hypoglycemia. Very good, Chandrasekharan. It is called Whipple's triad. Superb. Right? And they will be having documented hypoglycemia. That means when at the time of the presentation of the clinical manifestations of hypoglycemia, if you check the blood glucose levels, they will definitely have the hypoglycemia. And disappearance of the symptoms, right? Disappearance of the symptoms upon giving the glucose, right? Disappearance of the symptoms upon giving glucose. That is what is your Whipple's triad. That is what is your Whipple's triad. Now you see our patient is having the features of your hypoglycemia, diaphoresis, asthenia, near syncope, clouding of consciousness. All that they are suggestive of your features of hypoglycemia. And at that time the blood glucose was done, it is around 43, right? It is around 43. Now the question says very clear, the insulin levels are elevated. Normally what should happen? Normally what should happen? Whenever the blood glucose, right, whenever the blood glucose reduces, the insulin levels also should reduce. Right, the insulin levels also should reduce. This is the basic physiology. Why? As a part of the compensatory mechanism. Right, as a part of the compensatory mechanism, when the blood glucose level reduces, even the insulin levels also reduces. Right, then even the insulin levels also reduces. That is what should happen. But here what has happened? The blood glucose concentration is like 43. That means it is reduced, it is hypoglycemia. But if you take the insulin level is elevated, right? So this is not the normal physiology. There is some underlying problem. And what does the question says? No insulin antibodies. That means what? Your type 1 diabetes mellitus is ruled out. right? Type 1 diabetes mellitus is ruled out. Now, what is the other options like what we have now? The next important differential diagnosis like what we have is glucagonoma. Right, the next important differential diagnosis like what we have is glucagonoma. So in case of glucagonoma, sorry, I'm very sorry. Right, it is a case of insulinoma. So in insulinoma, in spite of hypoglycemia, right, in spite of hypoglycemia, these individuals, they will have very high insulin levels. They will have very high insulin levels because it's a tumor of the beta cells which will be producing excess amount of insulin. So whatever might be the glucose, it will be continuously producing the insulin. It will be continuously producing the insulin. And not only that, you take the C-peptide levels. What is C-peptide? C-peptide are the hormones which are being produced along with the insulin. If the insulin is being released from the beta cells, parallelly C-peptide also is released. So that is the reason why insulin levels are high and C-peptide levels are also high. Right? C-peptide levels are also high. So this is suggestive of your insulinoma. Now, how do you treat this insulinoma? Right? How do you treat this insulinoma? You have to do a transabdominal ultrasound to confirm the diagnosis of the insulinoma. And once you confirm the diagnosis of transabdominal ultrasound, then refer the patient to surgery for resection. Right? Then refer the patient for surgery to the surgery for resection. So this is what is your insulinoma. Yes, yes, Chandrasekharan, whatever you are saying is correct. The individual is having hypoglycemia, right? The individual is having hypoglycemia because of increased insulin, right? Because of increased insulin secondary to insulinoma, right? But what should happen? Whenever the blood glucose decreases, the normal physiology is that the insulin level should reduce. That is what is a normal physiology. But in our patient, because there is insulinoma, in spite the blood glucose levels are reduced, the insulin levels are still elevated. Right? The insulin levels are still elevated in spite of the insulin level, in spite of the blood glucose level being reduced. Now, because your C-peptide is also elevated, why do you want the C-peptide being elevated to be noted in your question? Because sometimes the insulin level can be elevated because of exogenous insulin administration. And in exogenous insulin administration, the C-peptide levels will be normal. But if it is endogenous insulin production, then the C-peptide levels are also high. Then the C-peptide levels are also high. Okay. Now, so yes, so the very important thing is endoscopic ultrasound and then do surgical resection of the tumor, right? And what are the other modalities? One is your endoscopic ultrasound. Next is triple phase spiral computed tomography, MRI imaging, and then octreotide scan. And then the octreotide scan. Once you localize the tumor, the treatment of choice for insulinomas is surgical resection of the tumor, right? Surgical resection of the tumor. And what is that you will do in the surgical resection? Depending on the lesion, surgery may range from enucleation of the insulinoma to total pancreatectomy, right? Either you do enucleation of that particular insulinoma or you completely remove that particular pancreas. Right? And medical therapy is less effective than tumor resection, but can be used in patients who are not candidates for surgery. And what is that medical therapy? That particular medical therapy, that is your diazoxide. What does this diazoxide do? Diazoxide will reduce the insulin production. What are the other medications for insulinoma? Verapamil, phenytoin, and as well as the octreotide. So if you see our question now, right, if you see our question, and yes, Shahid Afridi was telling begin diazoxide verapamil and have the patient appear for a follow-up visit in 3 months. No, medical management is not the treatment of choice in this patient. Right? Medical management is not the treatment of choice in insulinoma. What is the treatment of choice in insulinoma? It is the resection of the tumor, which is the treatment of choice. And how will you resect the tumor? First, you localize the tumor with the help of the imaging studies like endoscopic ultrasound or trans-abdominal ultrasound. Once you localize the tumor, once you fix the tumor, then the next thing is immediately refer to the surgery and see that the surgeon removes that particular insulinoma. And thereby, the clinical manifestations will improve. Thereby, the clinical manifestations will improve. Right? Now, we will discuss one more question and then we will wind up. Okay, so before that, you see here, how to work up for hypoglycemia. A patient has presented to you with history of hypoglycemia and you have checked the insulin levels. You have noted that the insulin levels, they are increased, right? You have noted that the insulin levels are increased. And once the insulin levels are increased, immediately check the C-peptide levels. If the C-peptide levels are also increased, then that hypoglycemia, whatever the patient is having, is due to endogenous insulin production. But in spite of increased insulin, if the C-peptide levels are reduced, then in such case, it is hypoglycemia due to increased exogenous insulin supplementation. Right, exogenous insulin supplementation. So why you have to measure the C-peptide? In order to check whether the insulin which is being elevated is endogenous insulin production or it is exogenous insulin supplementation. Right. So that is the reason why you need to check the C-peptide levels in a patient whom you find that there is increased insulin levels. Okay. Now, then followed by that, we will take up one important last question and then we will wind up the session. A 40-year-old man is evaluated as a part of an executive physical examination. He has read about different screening procedures on the internet and is interested in being screened for hemochromatosis. Right? He wants to get checked for hemochromatosis. He is otherwise healthy and takes only a daily multivitamin. But why do you think that he want to be screened for hemochromatosis? Because his father died of cirrhosis of liver at the age of 56 years. And his father also drank alcohol very badly. Now, the point is, there is no other liver disease in his family. Which of the following test is the most appropriate first step to screen for this disorder? Right? Which of the following tests is the most appropriate first step to screen for this disorder? Genetic testing for C282Y mutation, HFE activity assay, liver MRI. Screening for hemochromatosis is not cost effective and it is not advised. Transferrin saturation and serum ferritin. So the question is, what is the first step to screen this disorder? Yes, so Shahid Afridi is asking a question. He says that, sir, if C-peptide levels are normal or increased, you're asking in type 2 diabetes mellitus, what will happen to your C-peptide levels, right? Now, yes, Shahid Afridi, in type 2 diabetes mellitus, please tell me what will happen to the insulin levels. Yes, Ms. Afridi, what will happen to the insulin levels in type 2 diabetes mellitus? You answer this question, then I will answer your question. Right, so meanwhile, very good that you people have answered this. Transferrin saturation and serum ferritin is a correct answer. No. Please don't get confused. So insulin levels in type 2 diabetes mellitus in early stages where the beta cells are active, the insulin levels will be increased. And that time, obviously, the C-peptide levels are also increased. Whereas in later stages of type 2 diabetes mellitus, the insulin levels will be reduced. Right? The insulin levels will be reduced. and that is the point when the C peptide levels are also reduced. That is the point when the C peptide levels are also reduced. Okay, so in early stages the C peptide levels are high. In later stages the C peptide levels are low. Right? Yes, Shahid Afridi, is that clear? Right. So once you're clear with that, then we will move on to this question on the hemochromatosis. So in hemochromatosis, let me tell you, it is due to, if it is like hereditary hemochromatosis, right? If it is hereditary hemochromatosis, there will be HFE gene mutation, right? HFE gene mutation. But what is the question asked? Most appropriate first step to screen to this particular hemochromatosis, right? So now you see the flow chart. In individual whom you have suspected hereditary hemochromatosis, the first thing what you have to check is either transferrin saturation, right? Either transferrin saturation, or you need to check for the unsaturated iron binding capacity, UIBC. If suppose transferrin saturation is more than or equal to 45%, then next step is you have to do the genotype analysis. Right? The next step is you need to do the genotype analysis. And once you do a genotype analysis of HFE gene, in such case, right? In such case, if the genotypic abnormality is there, then you need to confirm it is hereditary hemochromatosis. Okay. So how will you approach to this patient? If serum ferritin levels are less than 300, observe the patient. Don't do anything. But if the serum ferritin levels are 300 to 1000 milligrams per liter, do a phlebotomy. And if the serum ferritin levels are more than 1000, do a liver biopsy, confirm the iron overload, and then you need to do phlebotomy. Right? Then you need to do phlebotomy. Okay. So now my conclusion to this particular question is that in hereditary hemochromatosis, the initial screening test is your transferrin saturation. This transferrin saturation should be more than or equal to 45%. Then you have to do HFE gene mutation analysis, in which you classify the patient into mild, moderate, severe. Serum ferritin less than 300, mild. Serum ferritin 300 to 1000, moderate. Serum ferritin more than 1000 milligrams per deciliter, severe. And what do you do that in mild? Nothing, just observe the patient. What is that you will do in moderate? Phlebotomy. What is that you will do in severe? You do liver biopsy and confirm the iron overload, and then you need to do phlebotomy. Right? So that completes the today's clinical based questions of today. Right? With this, I will wind up the today's session. I'll just summarize what we have discussed today. So our first question was on osteoporosis. In this, I have taught you about what is T-score, what is Z-score, what is the normal bone scan, what is the normal levels, and why in cystic fibrosis you will have vitamin D deficiency, and how frequently you have to do bone density metry. That is what I have taught you in the first question. Second question is about the osteogenesis imperfecta, right? I have said you what is the mutation in osteogenesis imperfecta and what are the types of osteogenesis imperfecta, and I have also said you the concept of blue sclera in case of the osteogenesis imperfecta. Then followed by this, we have discussed about the insulinoma, right? We have discussed about the insulinoma, where the insulin levels are very high in spite the individual having hypoglycemia. Right? And in these individuals, surgical therapy is the treatment of choice then compared to that of the medical management. Right? So that is about your insulinoma. Right? And lastly, we have discussed about the next important topic, that is hereditary hemochromatosis. How will you diagnose and how will you treat? Right? So this is for today. And tomorrow again, more or less the same time, I'll be there in front of you live to discuss some more clinical based questions which are definitely useful for your upcoming FMGE exam. So we have another 6 days or 7 days for your FMGE exam. Please do a proper revision at this moment of time, which is very much required. Don't read any particular new things at this moment of time, where you cannot absorb anything, and please don't feel stressed or tensed about the exam, right? So prepare or do your maximum, then definitely the luck favors for you in your exam and you will definitely clear the exam, right? So thank you very much and see you tomorrow.